from New Delhi, and there would be different time zones everywhere in the world. This is a unique opportunity for us, joining hands with World Gastroenterology Organization and Asian Pacific Association for Study of the Liver on the World Hepatitis Day. But before I start and say something, I would like you all, I know that everyone knows we have lost a legend in hepatology, Professor Roger Williams. He was a true visionary, a mentor, a guide, a leader, an investigator, and a perpetual student. He will always be remembered. Everyone has hundreds of stories with him, but I can only say that there is no substitute. There cannot be another Roger Williams. With that, I would like you to have a small condolence of maybe 15 seconds to pray for his soul in heaven. Thank you all for being with us and praying for the departed soul. I would now, in the limited time, would like to, the session plan as of now is based on two main themes. One is the clinical management of hepatitis B in the infected individuals, and second is in public health issues and research activities related to hepatitis B in Asia Pacific. Now, since we have WGO and we have President WGO with us, we will probably reach out all over the world. And I would also like to say that the moderators would try and moderate the time. I won't take much, except that at the end of the session, I would have a panel with Patrick Kennedy. So we'll try and handle those which are not answered. And now I would ask President WGO to say a few words.
Okay, thank you, Mr. Chairman. Hi, everybody. I am Naima Amrani from Morocco, the President of the World Gastroenterology Organization. It's our great pleasure to participate at this summit, jointly organized by the Asian Pacific Association for the Study of the Liver, APASL, and the World Gastroenterology Organization, WGO. As a global guardian of digestive health, serving the world, the role of WGO is to increase global public awareness of gastrointestinal and liver disorder, to provide high-quality educational opportunities to medical, nursing, and other healthcare professionals in the field of hepatology and gastroenterology throughout the world, and to promote international collaboration in digestive health education, training, and research. To accomplish this vision, WGO has developed a rich, relevant, and challenging program across the world that train, educate, advocate, and inform. We don't have time to go into detail, but let me just remind you some of these programs. We have 23 training centers established worldwide. And while the view is global, WGO emphasizes the developing world, especially area where access to high quality training in hepatology and gastroenterology remain an issue. We have also TTTs, train the trainers, which is another exciting program designed to disseminate teaching skills over the world. Our committees and interest groups are very active in many areas, especially in hepatology, and this gives me the opportunity to thank Professor Said Hamid, the chair of the hepatology interest group, for his work and the successful achievement he is done with his committee. Some of our guidelines, global guidelines with Cascade, are dedicated to hepatology. And also the World Digestive Health Day is another WGO activity that we can share with APASL, for example. For example, together we can try to find the missing million for the hepatitis free future. Dear all, We're really delighted to participate at this great event and look forward to collaborate more together with APASL in the large field of hepatology. On behalf of WGO, I would like to thank and congratulate the organizers, especially Professor Tarisak Tanawandi, President of APASL, and Professor Shiv Sharan, Chairman of the APASL Steering Committee, for getting WGO involved. At the same time, it's also my pleasure to invite all of you for effective participation to our upcoming events. The first one will be this year. It's Gastro 2020 Prague, which will be held in Prague with the Czech Society of Gastroenterology from 3 to 5 December 2020. And the second is the World Congress of Gastroenterology of 2021, which will be held in partnership with the Emirates Gastroenterology and Hepatology Society in December from 12 to 15, 2021. So please save the date and be present. Finally, I would like to wish you a successful summit and thank you for your attention.
Thank you very much, President, and we are very happy, and our President also, Professor Tanwandi, would be speaking later. But in the interest of time, I would now pass on to the Chair, Professor Edgain, and Professor Manoj to take the session forward. Thank you for joining.
Thank you, Shiv. I'm Ed Gain, and I'd say good morning or good evening from New Zealand. I'd just like to start off by echoing Shiv's tribute to Professor Williams. For me, for 25 years, Roger has been a teacher, a mentor, and a close friend. So he will be surely missed by all of us. Now,
request everyone to kindly mute their mics and the videos. Just the speaker may be kindly speaking. Thank you so much.
Our first speaker for today is Dr. Tanwandi. He is a hepatologist at Sriraj Hospital, Bangkok, Thailand. He is the current president of APASL. He has published more than 80 articles, and he is currently member of AGA, ACG, EASL, and APASL. And he will be speaking on selection of treatment modalities in patients infected with chronic HBV in the COVID area, interferons or antivirals. Professor Tanwandi, please start.
Thank you, Manoj, for a very nice introduction. So actually, my talk going to be after Professor Locke mentioned regarding the criteria for the treatment, but you can recap that and afterward. So my task going to talk to you whether in this pandemic with COVID-19, whether the NUC or interferon going to be the preferred treatment. As we are aware that COVID-19 is still around, and this is the survey from WHO several weeks ago regarding disruptions of hepatitis services around the world. So there are going to be some disruptions of hepatitis service, or that's going to be the problem because of the healthcare system is saturated by the COVID-19 in many countries. Not only for the treatment, but also for the new diagnosis, as well as you can see here, that hepatitis B testing is reduced in many countries. However, we have the goal, as WHO has set the goal by 2030 to diagnose more than 90% of the burden and treat those who are eligible for the treatment up to 80% in order to reduce morbidity, mortality by 65% within next year, 10 years. So it's going to be very close. 10 years is not that far. So the goal of the treatment so far is to, as I said before, that to reduce the morbidity, mortality by improving survival, quality of life, and reductions of hepatocellular carcinoma. Nowadays, we have two options, whether interferon, which is now is PEG, and 6 nucleoside analogs, from lamivudine to the latest one is TAF or tenofovir alafenamide. So for the nucleoside analog, this is the direct inhibitions of the viral replication, while interferon has two actions by reductions of the replication of the virus as well as stimulation of the immune system. So it's going to be dual actions. Shown here is the study done several years ago, E-positive by Professor Loud, George Loud, who's here in the panelists, with PEG-2A 180 microgram weekly for 48 weeks. And on your right is in E negative. So at the end of the treatment, 6 months after stop the treatment, in E positive, about a third of the patient can achieve E zero conversion. And also in E negative, about a third of the patient can achieve ALT normalization plus HPV DNA less than 20,000 copy per mil. And a few percentage of the patient can have S antigen loss. Please note that those days in the patient with significant fibrosis, the endpoint was 20,000 copy per mil, which is nowadays 20,000 per mil is not acceptable in the patient with significant fibrosis. However, for the meta-analysis of interferon in the treatment of chronic hepatitis B, it's shown that it can reduce the development of cirrhosis and hepatocellular carcinoma. Even most of the study was small, included in the meta-analysis. So the good candidate for PEG interferon going to be the patient with low baseline DNA, high ALT, and genotype A or B, in the patient with young, without comorbidity, and compensated liver disease. Then, what is the side effect of interferon? As you can see in this slide, this is derived from E-positive study by Professor Lau. So you can see that either interferon alone or in combination with lamivudine, more than half can have flu-like symptoms, especially fever, fatigue, myalgia, as compared with very few percentage in lamivudine groups. Then when we compare with the COVID-19, so you can see that about similar of the presentation of COVID-19 nowadays as compared with the side effect of PEG interferon. Then when we use interferon nowadays, especially in the country where COVID-19 is still prevalent, it's going to be confusing whether it's going to be side effects of interferon or COVID-19. Moreover, during the course of PEG interferon treatment, there could be some flare. Early flare induced by the host, this is good flare, or later, after the treatment, there's going to be bad flare induced by the virus. So this flare can be seen in the patient with COVID-19 as well, up to 50%, as you can see from the recent study by Professor Sarin for the COVID-19 study. The spectrum of the ALT abnormality, even in the patient without cirrhosis, still more than 50%. So during the course of the PEG interferon treatment, the ALT flare going to be another issue that we do not know whether it's going to be by interferon or COVID-19. This side effect make us to monitor the patient more frequently, and this needs in-person visit. So in order to measure the side effect, and sometimes we need to measure the on-treatment response. Overall, interferon is more expensive, but it is finite. About a third achieve viral control, so 2/3 still need another treatment. And during the pandemic era, the interferon in terms of shipment is going to be stored and shipped refrigerated. Now, for the second option, antiviral agents, so I'm going to focus on entecavir, tenofovir, and TAF, which is more potent and a high genetic barrier. Especially for tenofovir and TAF, this is going to be eligible for both naive and lamivudine failure. And all of these three agents nowadays, they are generic available. So it's going to be very cheap and good for long-term treatment, especially in developing countries. I go back to the original PEG treatment in E-negative. This is a study done from Korea regarding the comparison between the patient with complete viral suppression with the patient with low viral suppression but still detectable, whether intermittently or persistently, but still very low. So the incidence of Hcc is higher in the patient with either intermittently or persistently detectable HPV DNA. And this is the study from Asian country. This is just examples of study from Asia site where tenofovir seem to be more robust in terms of reductions of HCC, but it's not true in the Western. Maybe when I look at the study in Asia Pacific, whether from Korea, from Hong Kong, this is from Hong Kong, more E positive subject and higher viral load in our group of the patient as compared with the study from the Western. In terms of tolerability and safety, the nucleoside analog is going to be the most very safe, very minimal side effect, and it can be used in all patient subgroups, whereas PEG interferon is contraindicated in decompensated and in many subgroups of the population. And for the continued treatment of chronic hepatitis B, all guidelines have recommended continue the treatment as well as for those who need the treatment. So we need to initiate the treatment, but we try to limit elective blood donor, in-person visit to the hospital. So in conclusion, it is the clear choice that during this time of COVID-19 pandemic era, high potency nucleoside analog could be the first choice. This is going to be eligible for the treatment because it is simple, safe, it is eligible for multi-month dispensing and do not require cross monitoring of the side effect. And actually, we should adopt this simplicity amid of the COVID-19 pandemic to achieve HPV eradication within the next 10 years. Even after COVID-19 pandemic era, we should make up our mind to make it more simple for people to follow. Thank you.
Thank you, sir. So we'll start the discussion and I will take the first question. So, sir, is there any evidence that interferon use increases the risk of coronavirus infection in any way?
Yes, I think there is the studies of actually interferon itself can have effect, have effect on coronavirus as well. So there were studies used beta interferon for the treatment of coronavirus. So it's safe, but it's still in the early phase of the study.
Okay. We have some questions from the participants also. This is a question from Dr. Sitaram Chaudhary from Nepal. He is asking, can interferon with any drug combination ever cure hepatitis B?
Can you repeat it?
Can interferon with any drug combination ever cure hepatitis B? Is there any possibility of curing hepatitis B?
Nowadays, I think the combinations of interferon and NOC has shown some benefit, but most of the study was small. So actually, interferon itself can, at least in terms of functional cure, can lead to S antigen loss a few percentage, 3 to 4%, and increasing over the time. However, combination with NOC so far especially for the pivotal phase 3 study, did not show any significant add-on of nuke. We need more drugs. I think that's could be covered by Professor Loccanini later regarding the cure of hepatitis B.
Yeah.
Professor Tawandi, thanks. It was a very clear presentation and very clear conclusions. But you did mention what many studies have observed, that there is an increase in liver function abnormalities in patients with COVID-19 infection, probably related to the general systemic effects of the infection. But do you think that the criteria for starting nuke therapy should be different in patients who have chronic hepatitis B and are viremic if they become infected with COVID-19?
I think this could be a very difficult decision when the patient come in and then with COVID-19 and found to be surface antigen positive and high viral load. So it's going to be very, very difficult. But I think if the patient is still compensated and there is no evidence of advanced fibrosis, maybe you can wait. But in the patient with significant fibrosis or the patient with cirrhosis, I don't think that's going to be, or in the patient with very high viral load, I think maybe the nuke should be initiated.
So at this time, you'd say we'd follow the current accepted guidelines for starting treatment?
We cannot, strictly follow the guideline for initiations of the drugs for chronic hepatitis B mentioned by the APASL or ESO or ASLD in this particular term. But I think in order to prevent reactivation of hepatitis B in the patient, I just focus on those with significant fibrosis by other method, not just only elevations of the enzyme alone.
Thank you.
Okay, we can take one more last question. This is from Dr. Bhupender. He asks, which group of patients will benefit most from interferon in this COVID era?
I don't think there is no specific groups of, actually there is no such study nowadays. And actually interferon, which was popular several years ago, 10 years ago, and nowadays, most of the guidelines mention interferon, but I think currently, there is no specific population that's going to be beneficial from PEG interferon during this COVID-19 era, except for those who are very motivated and can come to the hospital quite quickly for the the side effect monitoring and also the drug resupply.
Thank you, sir. There are many more questions, but in the interest of time, I would thank you, Dr. Tanwandi, for this lecture. Okay, welcome, ma'am. So next lecture will be by Professor Anna Locke. I will introduce her. She is Dame Sheila Sherlock Distinguished University Professor. She is Alice Lohrmann Andrews Professor of Hepatology, Director of Clinical Hepatology, Assistant Dean for Clinical Research at University of Michigan, USA. Her research areas primarily focus on hepatitis B with more than 550 papers. She has been the president of AASLD in 2017. She has received many awards throughout her career. And she will be speaking on assessment of treatment candidacy of patients infected with chronic hepatitis B in this COVID era. Non-invasive only, or we should do liver biopsy also. Professor Locke, please. Thank you.
Okay. So first of all, thank you to APASL for inviting me to give this presentation. I was asked to talk about assessment of treatment candidacy in patients with chronic hepatitis B infection in the COVID-19 pandemic era. So the first slide shows my disclosures, and this is an outline of my talk. I would discuss the goals of hepatitis B treatment, the outcomes in untreated patients, the efficacy and limitations of currently available treatments, the indications for treatment, and the assessment of candidacy for treatment and how we would adapt in the COVID-19 pandemic era. So first, what are the purpose of treatment? Obviously, we want to prevent progression of liver disease to cirrhosis, liver failure, liver cancer, and death. We also want to decrease symptoms and improve the quality of life of our patients. Hepatitis B is associated with stigma, and we would like to be able to remove that and also decrease infectivity and the risk of transmission. But what happens if we don't treat patients? We all know that there is a risk of progressing from acute to chronic infection, particularly if the infection is acquired in children. And in those with chronic infection, there's a risk of progressing to cirrhosis. But treatment can also reverse that process. And once cirrhosis sets in, there is a risk of liver cancer, liver failure that might lead to liver transplant and death. Hepatitis B, unlike HIV and hepatitis C, patients can have immune control with suppression of virus replication. They can also benefit from treatment, but this is what may happen in the absence of treatment. Now, why is it that some patients progress and others don't? We do not have all the answers, but we know that there are virus factors, host factors, and environmental factors. Older age, men, and perhaps genetics, and now increasingly obesity and concomitant NAFLD may play a role. We know that in patients with chronic hepatitis B, they have impaired immune response, and whether there are genetic differences is unclear. We know the virus plays a very important role, and certain genotypes and molecular variants have a higher risk of going on to liver cancer. The last 15 years, we have also known that patients with higher viral load are at increased risk of adverse outcome, as is concomitant infection with HIV, hepatitis C, and Delta. There are also environmental factors such as alcohol, exposure to carcinogens, and some studies also suggest smoking increases the risk of liver cancer. Well, what treatment do we have right now? We have interferons, and we have the oral antivirals. We have not had any new treatment, essentially since 2008, because tenofovir alafenamide is just a new formulation of tenofovir disoproxil fumarate. Nonetheless, the development of oral antiviral in the 1990s was revolutionary for hepatitis B, because these drugs are very potent in suppressing virus replication, and through that reduce liver inflammation and fibrosis, prevent progression to cirrhosis and liver failure, and also decreases the risk of liver cancer. But more importantly, these oral antivirals have demonstrated long-term safety. There are, however, limitations with current treatment. While they suppress the virus, they do not completely eradicate the virus. They certainly do not eradicate the Hcc DNA or the integrated Hpv DNA. There's a very low rate of HBs antigen loss, particularly with the non-A genotypes. And for many patients, long duration of treatment is required because virological and clinical relapse.
The most recent infection, the situations report in Japan. Actually, Japan is composed of four islands, and we are in the middle, main island, and Tokyo is the center of that main island, and most concentrated population and the most concentrated infections occurring. Chiba, actually where I'm living, is east of Tokyo, and Kofu, which now I'm talking about, is in the west of Tokyo. So in the middle, there is the sources of the infection actually present. And then we try to block and then conduct daily hospital clinical practice. That's the situation. And then I tried to check every single hospitalized patient when they came by PCR and by pooling method. What is a pooling method? I may explain. If there is a positive samples, positive patients, actually depend upon the viral load, high, intermediate, and also low. And take one of each and mixed by negative sample, 4 samples. So dilution is a ×5 dilution mixtures. And the second group is composed of the 9 samples, negative samples, obviously, and then ×10 dilutions mixtures. And the third one is the lowest viral load, and then mix it, and by 19, so 20 times dilution mixtures, and then did the RT-PCR. And in this experimental procedures, whether we can actually catch the positive signals by several dilutions, and then if the high viral load mixtures, no dilutions, the virus amount is 10 to 9.3, but accordingly, you get down to 10 to 7.4 logs by 20 times dilution. How about intermediate ones? The starting 0 dilution is a 6.8 logs, and then down to 5.8, and then 20 times still we can detect, and we can measure as 5.1 log. How about the lowest ones that we can take? And then that was starting from 3.6, as was expected, still can become positive. So by mixing procedure or pooling procedures, we call the pooled RT-PCR. We started several months ago, but just this week, to cover, this is because we have to cover the 3,000 individuals, not just the hospitalized patients, but also our patients and the employees, 1,500 employees we have. So altogether, it's like a small city of 3,000. I have to protect. I have some responsibility for this. And during the past 4.5 months, from the March 11th, I took a mixed policies. Mixed policy means when the COVID-19 infection highly suspected, we take individual testing. It's called the individuals. So 100%, one by one. But the rest, for example, non-COVID infections, not highly suspected about COVID-19. Of course, there are so many patients. And also our staff members, as I said, 1,300 plus members. We took group or pooled methods. And then actually we are able to make from 2 nasopharyngeal swabs to 21 nasopharyngeal swabs as one pool. And then by doing 530 tests, it's only 14% of the total. In other words, 86% reduction number of the test. Then we can find out one single one. And in fact, it turned out there is one case, it was positive. So altogether, we are able to test at least by PCR with some loss of the sensitivity, 6,102 patient individuals by 2,701 tests. So this case, 56% reduction in terms of testing. It just happened this week when I took a look at Nature papers. They call this group testing. And then they are saying, pulling the samples from many people, and try to save time and the cost. And they are proposing 3 or 4 different ways to make a mixture, so pools. And then I don't want to go into the details, like some they call the cubic type. But anyhow, some you need still 3 rounds, while some cases you only need 37%, you only can have the 37% reductions. But in our cases, as I said, almost 50% or more than 50% reduction, but it's I took a mixed policy, so highly suspect cases, we checked one by one. But anyhow, by doing this, we are, until now, no infection occurred inside. Therefore, the question, daily clinical practice are not influenced by COVID-19 or not. So far, fortunately enough, not influenced, but I got to show the data. For the last 10 years, we have a monthly number of the surgeries in our hospital. And this is the data from the 2010 April till 2020, actually this year's May. And then in fact, in this particular case, there is one drop in May, in May, yes. But there was a quick rebound right after. So we are conducting the daily clinical practice without any influence by the COVID-19 infection so far. And these are the under the general anesthesia or under the local anesthesia, the numbers, no change. And no delay allowed, in particular for the patients who have the malignancy, whether the COVID pandemic or not. So finally, I touched on our patients. And we have actually 612 Hcv eradicated patients. And then we did the follow-up for 3.6 years. Actually, most of the patients treated in 2015, year 2015, after our trials. And then we checked not just the hepatocellular carcinoma, but all the post-DAA malignancies, and found out that all types of the cancer occurred 11.9% in the 3.6 years time. And if you divide hepatocellular carcinoma, it was 6.5%, and others, not hepatocellular carcinoma, others 5.4%, which is very close to the 6.5%. And then those included all sorts of gastric, colorectal, lung, prostate, uterine, ovarian, and esophagus. So in my clinics, a bunch of the outpatient clinic are full of the eradicated patients. I have to watch all malignancy, not just limiting to the hepatocellular carcinoma. And then there's a long debate on the treatment modality, especially those patients are followed so that they are found small and then liver function improving. So maybe the discussion can be on these algorithms on the left-hand side, resection or ablations. And in fact, in the past, there are 4 randomized control trials, and then 4 of them are from China. And then 3 are showing no difference between the open surgery versus RFA. And in Japan, for the last 10 years, we did actually initiated by the Dr. Makuchi and run by the surgeons, Dr. Takayama and then Kokudo, and then internists like ourselves. And then actually it was partially finished, and then it was presented in the ASCO last year by Dr. Izumi, and also this year by Tateishi. But the data is, there is no difference in between the 2, RFA and then surgery. So how this apply to my patients? And then from those eradicated, I saw 40 patients who developed hepatocellular carcinoma. How did I treat in real life? And then Arrowhead I choose in 48% cases, laparoscopic surgery, 35%, and then open surgery is only 13%, and others too. So updated way of treatment are not including the algorithms of the guidelines. Laparoscopic surgery, it seems like very beneficial, especially there are so many senior persons who are treated by DAA and eradicated and developed hepatocellular carcinoma. So the options are limited, and then only 13% cases went to the open surgeries. And the future studies, therefore, there are 4-5 studies about Arrowhead versus open surgeries, and then doesn't show much of the differences anyway. Future study could be between the Arrowhead and the laparoscopic surgeries. And then the way of the surgery is some surgeons only do non-laparoscopic classical open surgeries. Therefore, for the future's sake, we need more youngsters to be trained for the laparoscopic surgery. Finally, I will show our case, one case. This is a 68 male child Pew score B, and then after eradication of virus, 2 hepatocellular carcinoma are found. On the surface, S segment 3 centimeters, and one on the 2 centimeter on the deep in S1. In this particular case, I decided to send him to the laparoscopic surgery, especially on the one on the surface. And then Dr. Imro is an expert for this and successfully done. And then it was Edmondson grade type 2 and 3. I'm sorry to say my very personal things, but Hugh Edmondson came to my wedding parties in 1978, long time ago. He came to my weddings parties in Pasadena. Anyhow, sorry about it. Then this is a picture of that time. Then after 4 months, the other one, S1, deep in the liver, by Dr. Sheena and Juntental Hospital, it was done. So both are combined. Without opening the abdomens, we are able to succeed to treat the patients nicely by joint between the surgeons with the technique of laparoscopic surgery and also the Arrowhead. So again, I repeat, maybe we don't need time to stop, no time to waste. If I consider the patients suffering from these hepatocellular carcinoma malignancies. So, bye-bye. I hope I want to see you, everybody, face to face. Or I feel very sorry about not able to discuss details. Thank you very much. I'll stop here.
Thank you, Professor Amata. Do we have time for questions? Perhaps that's one question that Professor Amata is there. Is Professor Amata there, or is this recorded?
But I'm here.
Oh, good.
Yeah, question and answer.
You've shown that your institution has managed to carry on performing curative intent ablation and surgery as needed throughout the pandemic. Have you altered your surveillance programs for patients at risk, or do you carry on with the same intervals and the same modalities in terms of surveillance?
Well, you're asking the PCR is in-house. We are doing everything in our hospitals. And then that's why we can manipulate the way we want to do. And we are very fortunate enough because we have the staff which can do PCR or arrange the different types of settings. And in addition, we have a clinical staff. So, Jidon, I saw you, Jidon Zhao. How are you? How are you?
Fine, Professor Mata. Excellent talk. Really enjoyed it.
Okay, well, I think that's a sign, perhaps, that we need to move on. So
Yeah.
thanks, Professor Martin, and thanks to all the speakers in the first
thank you
part
very
of our
much.
symposium.
Yes.
And I'll hand over now to George Lau and Dr. Rawawi to introduce the second half of the symposium.
I will take a minute and first like to thank Edgain and Manoj for conducting this session very well, and to all the speakers. And I would like to introduce the two chairs. George needs no introduction to the hepatology world and can be said that one of the pioneers and leaders in the hepatology in Asia. We are very proud. I would like to introduce briefly Dr. Evari, who is also deeply interested into hepatitis field. He is a WHO expert in the Southeast Asian region, and I invite both of them for taking over in the interest of time to George and Dr. Evari. Thank you.
Yeah, thank you, Professor Sareen. It's our pleasure to chair these sessions, public health issues and research activities related to HPV in Asia Pacific region. Each talk will last for 15 minutes and we will have 5 minutes for discussions. The first speaker is Professor Jia Jidong. Professor Jia is Professor of Medicine, Director of Liver Research Center, Beijing Friendship Hospital, Capital Medical University, China. He has served as President of the International Associations for the Study of Liver from 2013 to 16, and also APASL 2009 to 10, and also Chinese Society of Hepatology. So may I have Professor Jia to give our talk on COVID-19 and viral hepatitis B and C elimination programs. Are we stepping backwards?
Thank you, Professor Lau. It's really nice to see you online. Then also, I would like to thank Professor Sareen, Professor Ahmad, and all the professors in APASL and around our region. Today, I'll share my slides. Let me see. Okay, can you see my slides, Professor Lau?
Yes,
We can see
yes,
very well.
Okay, thank you. So today, my topic is COVID-19 and Hpv and Lcv elimination program. Are we stepping backward? This is a very big topic. I just try to focus on some of it. First of all, let's just some update of the Hpv and Lcv epidemiology from our region. This slide and the following slide are gifts from Dr. Pauline Chang from WIPRO of WHO. She gave me just the updated slides. We can see over 50% of the Hpv or Lcv actually reside in our region, so-called Western Pacific region. You can see around here, we have around 6% of Hpv prevalence, and for Hcv prevalence around 0.7. This is has dramatically declined from the previous even higher rate, but it's still a little bit higher for Hpv than most of the rest part of the world. Then similarly, it's not surprisingly see that the consequence of Hpv and Lcv, I mean the Hcc, hepatocellular carcinoma. Again, our region account 60% of the total cases globally. So this means the disease burden is still very high. The good news is that the successful infant universal vaccination program upon all new babies in our Western Pacific region. This is already we achieved the goal of regional goal, less than 1% of surface antigen among children already achieved. We can see most of our region have already achieved the goal and verified by WHO, and still some of the islands that still need to finish the program survey completed, but the results is pending to be published. Overall, the prevention is very, very successful. Now, just recently, today actually, the new WHO recommendation on prevention of mother to child transmission, MTCT, of HPV. So this is try to be further strengthen the prevention of mother to child transmission. By doing so, we can see an even more quick, even steeper decline of surface antigen in very young age groups. Then in this guideline, in addition to the vaccination and Hpv, hepatitis B immunoglobulin, and also we can treat the mothers with very high viremia in the late pregnancy. So this would be a further step to further strengthening or further to reduce the surface antigen. So despite this kind of progress in prevention, we still have existing cases of hepatitis B and hepatitis C. But what's more important is we can see for HPV in the left panel, we only have 20% of them diagnosed. Around 20% of those diagnosed treated, and only very small percentage virtually have virus suppression, virus control. Similarly, the cascade also dropped very sharply. For Lcv, although we have very, very good cure, but still only very small percentage of patients diagnosed and treated, and only less than 1% of all patients actually cured in our region. So this is what we are facing, although we made progress. So fortunately, WHO encouraged countries to prepare their own national action plan for viral hepatitis prevention and treatment. So you can see in our region that by this year, we can see that more than half of the countries already have action plan. Some of them on the development. So I mean, many more already have this plan, but still have 15 countries, many in the Pacific region, still do not have a action plan. So we still need to do a lot of things. So this one slide showed accessibility and the coverage of the HPV medication and DAA for HCV. Fortunately, only, well, you see, 4 countries have no coverage, no insurance coverage, so still have to be out of pocket money that means paid by the patient themselves. All the other countries, you can see more or less they covered, they call it finance. That means they covered by the national basic health care insurance or by the government special funding. So there's also a good step forward. So in the treatment of viral hepatitis B and hepatitis C. But unfortunately, from the earlier this year, we experienced an outbreak of pandemic, so-called COVID. Already we have so many people affected, infected, and then many of them died. So in our region, we also have facing or still facing this very severe pandemic of COVID-19. So this just slide summarizes the COVID-19 or SARS-CoV-2 infection and the liver. On one hand, this infection of this virus may directly or indirectly through immune modulation, immune reaction to injure the liver via the kind of a lot of series of cytokine. At the same time, we can see that some patients have so-called pre-existing chronic liver disease like hepatitis B, hepatitis C, NASH, or other diseases. So that means COVID-19 biologically can affect people of the liver. So you can see, according to several meta-analysis, the liver injury, the incidence of liver injury in COVID-19 patients is around 25%, ranging from 16% to as high as over 50%. So you can see in patients with COVID-19, from 2 to 11% have pre-existing chronic liver disease. So all this cause the problem, pose challenges to us. So again, this slide showing the HBV, specifically HBV and Lcv co-concurrence. So we can see for HBV, mostly reported from mainland China, you can see some series as high as over 10% of patients of COVID-19 actually were chronically infected with HBV. Then those with HBV have developed more severe outcomes compared with those without. Then of course, for HCV, it's less problematic. So less than 1% have the patients of COVID-19 have this. So this is most large series in China. We can see over 1,000 patients. You can see that around 2% of patients have HBV, and over around 20% of patients have elevation of ALT and AST. And compared with those without HBV infection, those with HBV infection have a higher rate of elevation of ALT and AST. Again, confirm the previous summary of the data around the world. I'm sorry, this slide changed somehow. The picture becomes smaller, maybe just because of the compressed. The rate of 30-day mortality in patients with cirrhosis and COVID-19 in Italy also showing that those with higher child-Pugh score, those with Cliff score have worse outcomes. So anyway, this slide showing that's from the so-called APASL study, they organized by APASL, especially by, I think, Professor Sarin, Professor Ahmad, and also Professor George Lau. We can see in our region, we can see incidence of severe COVID-19 among chronic liver disease, common cirrhosis, and decommon cirrhosis is increasing. Of course, that means underlying liver disease do increase the severity of the COVID-19. The incidence of liver injury, again, is similar, have the stepwise increase among those with chronic liver disease without cirrhosis, with cirrhosis or decompensation. So this is, again, this related with the CTP score. If higher CPT child-Pugh score, the hazard is also increased. So that means we are facing this challenge. So in response to this, Chinese Society, Chinese Medical Doctor Association, together with Chinese Society of Hepatology, issued a protocol for prevention, diagnosis, and treatment of liver injury in COVID-19, organized by some of the professors like Professor Zhang Hui, Professor Wei Lai, Professor Hou Jinlian, and Professor Yin Qin, and some others you know very well. This published in Chinese, it helped the clinical doctor to care patients with COVID-19. So that similarly, APASL published an expert panel consensus recommendation for patients with HBV and Lcv during the COVID-19 pandemic. So overall, I think if the patient already on treatment for HBV or Lcv, we need to continue. For those with non-COVID-19 patients, we still continue the treatment. For newly diagnosed patients, we may initiate the antiviral therapy of HBV or Lcv if clinically indicated. That means we have to balance the strength of resource and the emergence urgentness of this disease. For HBV, for those with COVID-19, if already on treatment, we still need to continue. If no not started yet, we need to consider whether the patient have flare of hepatitis B or patient plan to receive the immune suppressive therapy. That means we need to consider treatment to prevent the flare, the reactivation. For HCV, usually we do not start the treatment. AASLD and EASL published a similar guideline. I don't need to go to further details. I just want to emphasize we need to take care of patients with HPV and LCV, even those with cirrhosis or with Hcc, or those patients need liver transplantation. So this slide summarizes what I've talked about, what I need to do for patients with chronic liver disease, for LCV, HPV, or other liver diseases. In China, in response to this, we can now prescribe patients with 3 months of medication for HPV or HCV or cirrhosis. We can have internet clinic. We can deliver the medication by email service. We have a lot of online webinars for viral hepatitis prevention and control. I think Professor Dr. Lau also attended and participated in a lot of activity. For World Hepatitis Day, in the last days and today in Beijing and other part of China, we participated a lot of activities. So again, this slide, of course, today's activity organized by APASL. Then lastly, of course, this is a challenge. A lot of staff will redeploy, service may repurpose for COVID-19. Some services may shut down temporarily. The money will redirect it. However, we also have a chance. Now everyone understands health is a public good. Public health is very important. And innovation in delivery of service, like as I mentioned, the internet clinic, and also try to do a lot of things we cannot do before the outbreak of COVID-19. So finally, I would like to just say, despite the pandemic of COVID-19, we are not stepping back forward in the control, in the elimination of our hepatitis B and hepatitis C. We are still moving forward, although a little bit slow, but we are going forward slowly and steadily. So I hope by doing so, we can achieve our goal, so-called hepatitis-free future. Also, I remember many years ago, Professor Dr. Lau have a hepatitis-free generation. I think it's a similar mission. In the future, we have a hepatitis-free future. Lastly, I would like to thank special thanks to Dr. Pauline Chang, who worked at the West Pacific Regional Office, WHO, for her kindly providing the updated slides. Now this is in the middle, the lady, Dr. Chang. Thank you very much. Thank you for your attention.
Thank you, Professor Jia, for the excellent talk as usual. Because we are running out of time, I would like to leave the questions to the very end. So without undue delay, I would like to have our next speakers, Professor Sid Hammett, to give a talk on HPV immunization service during COVID-19 pandemic, the guidance. Professor Sid is a world expert in liver diseases. He worked at the Aga Khan University, Karachi, Pakistan, and his current work involves HCV micro-elimination projects in the province of Sindh, Pakistan, and he has mentored a number of postgraduate GI trainees, PhDs, and numerous students. He has held high positions in the Pakistan Society for the Study of Liver Diseases and has numerous publications. So, Professor Sid.
Thank you very much, Professor Lau, for the very kind introduction. And it is a great pleasure to be in this symposium, not just because of the title and the topic that is important, but also because of the fact that this is the first collaboration between the two societies that I currently represent or have represented in the past. So I'm currently the chair of the WGO Hepatology Interest Group, and I have been a member of the APASL Executive Council from 2006 to 10. So as it were, I have been on both sides of the fence, and it really is very, very heartening to see this, this collaboration coming together. It was Professor Sarin's idea when we met in the last Hepatology Interest Group meeting, and hats off to him that we have been able to put this together. Now, taking advantage of the fact that WGO has a large outreach, as was mentioned by our president, Dr. Naima Amrani, we have something like 120 member societies, GI member societies from all over the world. We thought we should do a little survey and get some real world information about what is happening in terms of the COVID-19 and hepatitis services. So I will talk about some bit of that survey, and then I'll talk about the immunization services and how that has been affected. So I have no disclosures which are relevant to the presentation. This survey we developed along with Professor Sarin's group developed this survey, and we put our inputs into it, and it was only released on the 19th of July. So we've had a very short time to receive the results and to analyze them. So this is a very rough cut. This work will continue, of course, and we hope that this will culminate perhaps in the largest global evidence that we have in terms of COVID-19's effect on the hepatitis programs. Already, we have 170 respondents from 89 countries across the globe. So this is truly a global representation. Questions related both to hepatitis B and C, but I'm just putting up the hepatitis B part because that is my topic. So let me go through this fairly quickly. So the first question was, has the COVID-19 pandemic changed your practice of diagnosis of patients with chronic hepatitis B infection? And there doesn't seem to be much change in that practice of diagnosis. Whatever people were doing before, they were continuing to do even after the pandemic started. There was a drastic change in some of these practitioners, but not to a great extent. The next question was, how often do you do a liver biopsy? Do you perform liver biopsy in the initial assessment of patients infected with chronic hepatitis B? This is the pre-COVID era. So about 60%, roughly 60% of people said they were not performing biopsies and they were dependent on other non-invasive methods of diagnosis. This percentage increased to nearly 80%. So the 20% who were performing biopsies before were not performing biopsies in the COVID era, and that is sort of understandable given the fact that people have to go to the hospital, they have to have some interventions, and so on. So they were not doing biopsies. Do you start new chronic hepatitis B infected patients on treatment during the COVID-19 pandemic? And 70% said yes. All cases were indicated they would start, but some were a little hesitant, saying only in cirrhotics with severe flares they would start, and some said they will postpone in all cases. But by and large, the majority would start new chronic hepatitis B patients on treatment during the pandemic. How has the COVID-19 pandemic affected treatment continuation of patients already on nucleoside or nucleotide analog? And this is a concern. 30% of these patients had treatment interruptions, perhaps due to not being able to go and get the medications, or maybe not even having the money to buy the medications if they were doing this out of pocket. And this seems to be particularly severe in Africa. We have yet to analyze this as on a regional basis, but we'll do that soon. But the major impact of this lack of treatment or discontinuation of treatment seems to have been in Africa. This was an interesting question. How often do you use pegylated interferon if no usual contraindications for treatment of chronic hepatitis B in the COVID-19 era? And about 40% were using interferon therapy still if if this was otherwise clinically indicated and there were no contraindications. Even in the COVID era, they would be using interferon therapy. So that's a little bit interesting. Regarding screening and surveillance of HCC in patients infected with chronic hepatitis B in COVID-19 pandemic era, what do you follow? So the large majority continue to do their usual 6-monthly imaging plus minus the alpha-fetoprotein protein. Some delay it, some use only AFP and blood markers, but the majority will continue to survey their HCC, their patients for HCC infection, which is very good. Regarding family screening of HPV infected patients in COVID-19 pandemic area, what do you follow? Always ask to go to visit and get screening along with the patient, a small minority, just about 20-25%. Ask to go and get screening done at a nearby laboratory, or delay screening, at least 1/3 of these patients. They will delay screening the family until the pandemic is over. What is your assessment regarding the effects of the COVID-19 pandemic on national viral hepatitis B and C elimination programs in your country? And nearly 30% of these programs have continued to run, but the majority have either slowed down or may have considerably slowed down. Nearly 52% of these programs have slowed down from their previous pre-COVID era. What do you think the goal of viral hepatitis elimination by 2030 is still achievable considering the COVID-19 pandemic? And there are certainly optimists in this group who say 42% said yes, they think the goals are still achievable, but there is a significant number of people who would say no, and the others don't know. So about 1/3 would say no, the goals will not be achievable. What is your assessment of available research funding for HBV in your country or region during the COVID-19 pandemic? And needless to say, there has been significant decreases in the availability of research funding, or slight decreases. There's hardly been a significant increase during this time. Regarding research output in hepatitis B during COVID-19 pandemic, what is your thinking? Again, a significant decrease, not surprising because the funding is not there. And finally, what do you think regarding national immunization programs for HPV during the COVID-19 pandemic? About 40% said they're continuing as before, but a good majority said participation by the public is slow and delayed, or the program is getting downsized due considering social distancing and other restrictions. So the programs have been affected due to the immunization program, due to the COVID-19 pandemic. So what I thought I'd do is pick Pakistan as a low middle income country and see what has been happening here. And some of this is actually quite frightening. The first case of COVID-19 was reported in Pakistan in February 2020. Since then, immunization services have continued to decline. Full immunization coverage in children declined from 240 in January to 190,000 in April, and declined further until now, until June, when we had our so-called peak, although we're not sure, we might have another peak after this. From January to June, a 25% decline in the Penta-3 coverage. And remember, Penta-3 is the pentavalent vaccine, which is the third dose vaccine, which is given to infants. Between March and April 2020, around 700,000 children missed the Penta-3 vaccination. They just simply did not turn up. And all this is UNICEF Pakistan's data, so I think there is some validity to this. Antenatal care services declined from 537,000 in January to 345,000 in April 2020, which means what? Which means that the birth dose did not get given in these nearly 200,000 pregnancies just in the month of April 2020. Most importantly, Pakistan, remember, still is one of the very few countries where there are occasional polio cases. almost 40 million children missed out on their polio drops during this period from February to July. And the main reasons that have been cited were restrictions on movement and concerns around the COVID-19 transmission, so that people just simply did not want to present to healthcare facilities with their young infants or young children. This is some data from the, and pardon that this is in a slightly messy form, but this is what we get from the programs. This is hepatitis B immunization rates from the hepatitis control program in the province of Sindh, which is where we are. It's a large province, about 60 million population. In February 2020, just before the pandemic hit, they were doing about something like 16,000 first dose HBV vaccinations. This dropped to 2,437 in June 2020. And similarly, the number of cases registered, both for hepatitis C and hepatitis B, have significantly reduced over a period of time. This is from the largest province that we have, the province of Punjab, population around 110 million. And these are immunization rates from their hepatitis control program. I think this is just one hospital. This is not the whole of the Punjab program. And if you just look at the right-hand side of the slide, that is the most telling number. So in January, they provided 2,601 people with hepatitis B vaccination. This dropped to 21 only in May and 224 in July. So it is nearly a tenfold drop of hepatitis B vaccination. This is adult vaccination. This is not childhood vaccination, by the way. What were we doing before this? Well, we were doing very well. We were this was one of vaccination was one of the parameters that the WHO would probably say that the world was on its way to meet the 2030 targets, even well before 2030. So 3-dose hepatitis B vaccination coverage in 2015 was considered to be around 84%. Of course, there were some lower, some higher regions, but on an average, 84% coverage, which was fantastic, and it would have really resulted in meeting the goal well before the 2030 deadline. What happens now is a little bit of a guess. We were not doing very well in the birth dose vaccination, only 35% coverage overall, although some sections were doing extremely well. The Western Pacific, for example, was leading the way, as has just been pointed out by Dr. Jha, with China and others, really doing remarkably well. Africa still not off the baseline, or a little bit off the baseline, and other regions don't even really appear. Emro, for example, doesn't even appear in this. So we had a lot of things to do in the hepatitis birth dose still, and this will obviously take a hit. Now, just a few words about the hepatitis B vaccine. This is something that I don't need to talk to this audience, but anyway, over decades, we know that this is a very, very effective vaccine. The data from Taiwan, 60% decrease in the incidence of HCC, 70% decrease in mortality from fulminant hepatic failure, 92% decrease in mortality from chronic liver disease. And this has since then been replicated in many other parts of the world. Excellent safety profile, cost effective, particularly as part of a strategy to eliminate vertical transmission of HIV, HBV, and syphilis. It is effective in most people, not 100% of people. In healthy adults aged less than 40 years, the 3-dose vaccine, which is administered 0, 1, and 6, reduces a protective antibody response in approximately 30 to 55% after the first dose, and greater than 90% after the 3rd dose. After the age of 40, there is a decline in response to a little less than 90%, and by the age of 60 years, 75% response rates. There are factors which are recognized as being leading to non-response, like smoking, obesity, some genetic factors, and immunosuppression. They are all associated with the lack of response to hepatitis B vaccination. The WHO recognizes the importance of HCC and other HPV-related diseases as global public health problems, and therefore they reiterate the recommendation that hepatitis B vaccine should be included in national immunization programs. And by and large, it has now been introduced in most of the world, if not all of the world. A comprehensive approach to eliminating hepatitis B transmission must address prevention of infections acquired perinatally and during childhood. And we are hearing a lot about this at this World Hepatitis Day, with the new guidelines coming out just today, released, and then that Dr. Jha mentioned as well. Reaching all children with at least 3 doses of hepatitis B vaccine should be the standard now for all national immunization programs. So the emphasis now really is on the birth dose vaccine. All national programs should include a monovalent hepatitis B vaccine birth dose, ideally within 24 hours. Having said that, although effectiveness declines progressively the days after birth, even after 7 days, a late birth dose can still be effective in preventing horizontal transmission and therefore remains beneficial. All infants who receive the late birth dose during the first contact with healthcare providers at any time up to the time of the next dose of the primary schedule should be given that late birth dose. So there's really the ideal is 24 hours, but there's really no defined limit. So this is the schedule: birth dose delivered within 12 to 24 hours. WHO says within 24 hours, other guidelines say within 12 hours. The earlier the better, I suppose. And then there is this little bit of difficulty that many countries in the world are now doing this or have been doing this as part of their API program. So they do the first dose at 6 weeks, the second dose at 10 weeks, the third dose at 14 weeks. And this is in the form of the pentavalent vaccine, which contains 4 other vaccines given at 4-week intervals. Now, the difficulty is that this is what Gavi provides to many countries around the world. And it is only now that they have come around to the fact that birth dose vaccination should also be provided as a monovalent vaccination. And of course, there's a lot of adult catch-up vaccination with the standard 0, 1, and 6 months in many of these programs I just alluded. So what will happen, or what has happened, or what can be the strategy in terms of the COVID-19 problem? If the series is interrupted after the first dose, the second dose should be given as soon as possible, and the third dose at least 2 months after the second dose. Remember, when we were young, we were saying, okay, you've missed the series, go back, start again from 0. That is not the teaching right now. If only the third dose is delayed, it should be given as soon as possible, even though it may be a few months later. Doesn't matter, just give it, and that should be effective. This is just, I took a screenshot. This was just from the WHO symposium that was being held concurrently, almost 2-hour symposium. And I don't think you can read the slide well, but this is the potential impact of disruptions to hepatitis B vaccination programs during the COVID-19 pandemic. And the gist of this is that nearly 5 million young kids would miss out on the birth dose vaccination all over the world because of the pandemic. And these are the kids who will then become chronic, many of them, and will then be candidates for the development of HCC. So in summary, globally, there has been major disruptions in the care of hepatitis B patients, in some areas at least, with interruptions in medications, interruptions in their routine screening and routine care, and so on. Vaccination services, including hepatitis B vaccination, have been significantly affected. WHO estimates, as I said, that nearly 5 million infants will not get adequate HBV vaccination coverage due to the COVID-19 pandemic and may be potential candidates for HCC development later on in life. Infants and young children need to be particularly, therefore, targeted for catch-up hepatitis B vaccination whenever the opportunity arises. As soon as the coast clears, we should really be going after these infants and young children and trying to vaccinate them. The world was doing well with hepatitis B vaccination coverage, and we need to get back to that level quickly. Thank you very much for your attention.
Thank you, Professor Saeed Hamid, for your excellent talk and taking us through how can this SARS-CoV pandemic affect the immunization services, and how can we go back on our bird dose, which is already up to 50% global coverage and even less in some of the other countries. Professor Jidongji also took us through the how COVID is impacting the treatment services. WHO also carried out a survey recently, and this showed that there is overall reduction in service provision across the health sector. Both hepatitis B and C testing services as well as initiations have been impacted, and in some instances there have been a disruption in the supply of direct-acting antiviral drugs also. But again, there is a silver lining on the patterns of HIV programs. Now many countries, at least 17 countries we are aware, who have adopted a monthly dispensing for hepatitis B drugs rather than a monthly or bi-monthly dispensation. So as we learn to live with COVID, basically we have to adopt ways how can we minimize these disruptions in services so that we don't lose the gains that we have already made. So another area which is being impacted is the research, particularly related to hepatitis. So we have our next talk by Professor Stephen, who is past director of World Health Organization, Regional Reference Laboratory for Hepatitis B and D for Western Pacific region. His current major research interests include viral hepatitis, hepatitis vaccine, and antiviral chemotherapy. He is the recipient of numerous awards, including William Prossoff Lifetime Achievement Award. He is author of 289 peer-reviewed articles, 24 invited editorials, and more than 100 book chapters. Professor Stephen currently has an academic appointment at University of Melbourne. Over to you, Professor Stephen, for your talk on research and new drug discovery in hepatitis B. Has it taken a backseat in COVID-19? Over.
Yes, it gives me, I'm Stephen Lochinini from the Victorian Infectious Diseases Reference Laboratory in Melbourne, and I'm giving a talk on the invitation of the APASL on research and new drug discovery in HPV. Has it taken a backseat in the COVID era? Let's address that. So today, I'll be able to answer that I don't think it has taken a backseat, because there has been many new classes of antiviral agents being discovered and trialed for hepatitis B. And what I've put for you here is a list of the current new molecules: capsid assembly modulators, or CAM, silencing RNA or RNAi, antisense oligonucleotides, other oligonucleotide approaches. There's been some immunological approaches as well. We might have time for hepatitis B delta co-infection. And of course, because of the complexity of hepatitis B, combination treatments will probably be needed. So let's see how we go. Well, this slide shows the viral replication life cycle and potential targets as highlighted on the earlier slide. This is taken from a recent review written by myself and Fabian Zulem and Dr. French down below. And you can see here that the life cycle that most people are familiar with, the first class is the CPAMs, or the CAMs themselves. They act at the step of reverse transcription. The RNAi targeting drugs act at the level of the RNA coming out from Hcc DNA. And the third group, the NAPs, or the antisense stop compounds, they act inhibiting directly surface antigen release. Unfortunately, we don't have any drugs or antivirals targeting the Hcc DNA, and so unfortunately we won't have time to cover those. Let's first have a look at the first group of the antiviral agents, which are the capsid-associated inhibitors. And the first one that I wanted to highlight is, of the three major groups, is from Assembly Biosciences in America. And they have a second generation core inhibitor that's very potent. And as you can see from this data that was presented last year at AASLD, this capsid assembly modulator is very effective at inhibiting at least 3 logs of HBV DNA
in a 2-week period, which is very, very potent. And the other key marker at the moment we're all following in hepatitis B is the change in pregenomic RNA in the blood from baseline. And that usually tracks a little bit behind the viral load change. And here it's just on 2.5 to 3 logs. But it's a very active group of compounds. And I think we're going to see much interest in this over the next few years. The other company that's actively involved in capsid assembly modulators is Jansen, or J&J. They have a new generation of capsid assembly modulators. Their lead molecule here is 0440. And you can see here that, again, like in the previous slide from Assembly Bio, their drug is very active and very quickly produces a greater than 3 log reduction in HBV DNA. Similarly, 2 to 3 log reduction in RNA, and a more modest effect on the core-related antigen. So again, another series of potent capsid inhibitors coming from Jansen company. The third group I'd like to mention is the GLS4, which is comes from a company in China, the Sunshine Lake Pharma, in collaboration with Peking University. And they've got an earlier generation capsid inhibitor that had PK and safety issues, and they've modified their treatment protocol to include a ritonavir boosting step, because these drugs are heavily metabolized by cytochrome P450 mediated metabolism. And they've changed the formulation of their compound and done a clinical trial, and the results are quite promising. So here you see the HBV DNA on this ritonavir boosted CAM is showing a good 2 to 3 log reduction, or even 4 log reduction in viral load. Not much effect on surface antigen or E. Oh, sorry. But also a potent effect on HBV pregenomic RNA, a 3 log effect. So what this teaches us is that drugs, even with unfavorable PK and PP pharmacodynamic issues, can actually be improved with boosting drugs like ritonavir to able to minimize the negative effect on the metabolism of the drug. There were significant flares observed in the high dose, and that will need to be followed up in the phase 2 study. Now, the next area that I'd like to touch on in this presentation is the targeting of the viral RNAs. There's been a lot of interest in silencing RNA, which is shown for you here, siRNA, and also antisense oligos. Now, the silencing RNAs, RNAi, gets metabolized or processed through the risk loading apparatus, and the risk loading apparatus is selective degradation of the viral RNA. In the case of the antisense oligonucleotides, the target is also viral RNA, and these are DNA molecules which bind to the HBV RNA, causing the hybrid DNA-RNA hybrids to be metabolized by the enzyme RNase H. And both of these are very effective antiviral agents, but delivery has always been a problem. And shown for you on panel B here is ways that chemists have actually modified these drugs, these RNA molecules, DNA molecules, to include GalNAc. And you put GalNAc on the end of the molecules, it makes it more likely to be taken up by the Acela glycoprotein receptor, shown for you here in this slide is Asvpr. And this improved delivery is theoretically at least hoping to increase the uptake, processing, and delivery of these potent molecules to the hepatocyte. Excuse me. The first drug I'd like to mention in this is the collaboration between Arrowhead Pharma, Certicles, that developed the Arrow HBV TRIM platform, which they subsequently licensed to J&J Jansen. And so that is now the compound J&J 3989. And this is the first study showing a combination analysis of combined with a nucleoside analog in expanded cohorts of patients with chronic hepatitis B, doing a dose ranging study. And you can see here, these investigators looked at a number of different doses and got very good effects in terms of surface antigen reduction in the 200 to 400 milligram range, shown for you here in the lower right-hand corner. Very, very good and heading in the right direction, declines in surface antigen. And because of the dose range initially studied, the company wanted to expand the cohorts to 100 to 400 milligram range to identify how low could they go. 25 and 50 milligrams were effective in reducing surface antigen, but appeared less effective than the higher doses. And the silencing RNA strategy seemed to be effective against both Hcc DNA as well as the integrated DNA-derived Hpv RNA. And overall the drug was well tolerated. It's given subcutaneously once a month for 3 months, and there was some very modest injection site changes which were adequately addressed. There were certainly no cases of ALT elevation greater than 3 times the upper limit of normal or bilirubin rises. The really excitement in the field at the moment is this study also from J&J Jansen looking at the triple combination therapy of 3989, their RNAi drug from Arrowhead, J&J 6379, their in-house capsid assembly inhibitor, in the background of nucleoside analogues. So this was a study, a longer term study of this triple combination to explore the ability of the CAM active drug, a continuous dosing for this period, with the 3 monthly doses of 3989. And you can see the steady decline in surface antigen shown for you here very nicely, with the decrease down to almost 2 logs. So the conclusions from this study out to day 113 is that the surface antigen decline during treatment, a 1.4 log reduction by day 85, almost 2 log reduction by day 113. All patients at enrollment had more than 1,000 international units per mil of DNA, and that showed rapid decline, not surprisingly. The quantitative RNA, Hpv RNA, also showed rapid decline of up to 7 logs. No serious adverse events were reported, and there was a noted grade 1 rise in serum ALT in 5 patients. So this is promising to go forward, and I think we'll hear more news about this in the next few months. The other RNA active targeting drug is antisense oligos, and this targets all Hpv RNAs. And ISIS, in collaboration with GSK, have developed what they call 2-mo antisense oligonucleotide for increased stability, which shows a potent antiviral activity over a 28-day study. So these were a mixture of E antigen positive and E antigen negative patients, given 6 subcutaneous injections and followed on a background of tenofovir and tenofovir follow-up. And it was pretty well. There was a post-treatment flare in a single patient with the Hpv and the surface antigen below the limit of detection. So the key viral markers are shown for you here. You can see that change from baseline in terms of surface antigen at the 2 doses explored, 150 milligrams, 300 milligrams, and the similar changes to Hpv DNA. There were some post-treatment flares with delayed rebound of surface antigen in 3 E antigen negative patients, which are being explored. But it gives promise for proof of concept that this approach could be quite a benefit. As I said, with these number of molecules available for treatment, it's now possible to consider and entertain possible other combinations. And this is a study from Roche looking at their locked nucleic acid for increased stability, antisense oligonucleotides, and a Tol7 agonist in a mouse model. And what it shows is proof of concept. I thought I'd include this for viewers' interest. And you can see here that during treatment, there's a significant decrease in the with the Roche Tol7 agonist, and these both in terms of surface antigen, DNA, and with and without the antisense oligo. What was interesting in this study was the as well as the control and viral markers, that there was a brisk B cell response observed, and the view was that the Tol7 agonist was the major driver of the antibody response. So this is a clear demonstration of the fact that a broad-based immune response is probably going to be needed in terms of achieving a functional cure. and a lot of interest was expressed in this presentation. The final group of compounds I want to look at is the what they call the STOP group. These are like aptamers, if you like, the complex oligonucleotides. People might be familiar with the NAPs from Replicore. These are a new generation of aptamers called STOPs, which stands for surface antigen traffic inhibiting oligonucleotide polymers. And this is an in vitro study which really looked very closely at the mechanistic basis for how the STOPs actually work, which is what the field needs. And you can see here is a Replicore equivalent, 1004, and it's much less potent than the current, these are from Alagos companies in America, a very potent dose-response effect in vitro. It's almost 2 orders of magnitude more potent than the current Replicore molecules, and shows a nice dose response. Here is a nice spread of the antiviral dose response effect compared to the Replicore compounds, which are a bit more of a cliff type effect. It's not what we want. So these compounds certainly inhibit surface antigen from multiple genotypes. They're reducing intracellular levels, which is very, very important. And they've had effects on other viral markers. One of the concerns about these compounds has been their ability to activate the immune response non-specifically. And the STOPs shown here had no immune activation in PBMC assays and showed synergy with the antisense oligos in reducing surface antigen. And they had good PK in terms of liver concentration. So I think we're going to see more of these aptamer type compounds in terms of their potency, good clinical dosing, no immune activation, and good PK. I don't think we'll have time for the delta, so I might move on from that. But just now to summarize, to answer the question of the APASL people asked me to address, there's been extensive research and new drug discovery in HPV at present in spite of the COVID-19 epidemic. I think the field has taken very good approaches in terms of developing COVID contingencies, and these seem to not be having a too adverse effect on the clinical trials. Novel antiviral targets have been identified, including direct-acting antivirals and viral RNA, and the adoption of liver targeting and improved PK/PD will, I think, broaden the armamentarium for hepatitis B. We've seen many examples now of combination studies being discussed between companies, which is good, and I think there is genuine optimism for functional cure in the future. Thank you very much for your time.
Thank you, Professor Stephen. It was really heartening to note that research has not taken a backseat and scientific community continues to explore newer options and newer drugs for treatment and newer modalities. So we'll move on to the next, we'll have the question at the end of the session. So move on to the next speaker, that is Dr. Mukta Sharma. Dr. Mukta Sharma is the Regional Advisor for Hepatitis, Tuberculosis and HIV in WHO Southeast Asia Regional Office. She has worked in public health in low and middle income countries for past 20 years, and she is very staunch advocate for decentralized responses and addressing the needs of vulnerable populations. She has been trained as an epidemiologist and social scientist in UK. She has worked with WHO for last decade in the technical roles, including one on the global guideline development. So Dr. Mukta will be talking on what are the WHO targets and what has been the progress on the WHO health sector strategy on hepatitis B and C globally as well as in Southeast Asia region. Over to Dr. Mukta.
Thank you very much. Good afternoon, good evening to all participants of this important meeting of the Asia Pacific Liver Disease Foundation. I am Mukta Sharma. I work for the World Health Organization in their Southeast Asia regional office. And I've been asked to speak on a little bit about what are the WHO targets for elimination and what has been the progress on elimination targets in our region, in Asia, but also globally. A quick outline of my presentation. I'm going to say a few words by way of introduction to the concept of elimination, what the global and the regional situation is. I'll say a little bit about what does it entail when we say elimination and a hepatitis-free future. What does that actually mean? I'll say some words about opportunities and gaps, and then I'll summarize and say what the way forward might look like. You may all have heard of the Global Health Sector Strategy on Viral Hepatitis. This was set up in 2016 as a 5-year plan, and this really followed a very clear outline in the SDG 3.3, looking at controlling and eliminating hepatitis as a public health problem by 2030. In terms of deaths, what that means is that they are looking for a 65% reduction overall in mortality between the baseline of 2015 and 2030. And in terms of new infections incidence, the target is a 90% decline in new infections between 2015 as a baseline and 2030. There is a sort of target in 2020 for mortality as well as incidence, and that is 10% reduction in mortality in 2020 and a 30% reduction in incidence in 2030. Now, just to say, where were we at baseline, and are we expecting that things have really moved on? And these, if you look at the interventions on the left-hand corner, you have vaccination, you have prevention of mother-to-child transmission of hepatitis B, you have blood safety, you have injection safety, harm reduction, particularly for people who inject drugs, diagnosis and treatment of Hep B, as well as diagnosis and treatment of Hep C. And you can really see that there's quite a lot of progress on the first 4 indicators, first 4 interventions, sorry. But if you look at the other 5, testing and treatment, as well as harm reduction, then of course we're starting from a very low baseline and there is a long way to go. There are no new data at the moment to give us an update on these indicators globally for 2020. We are in the process of collecting data and analyzing and reporting data at the World Health Organization. Countries have reported to us, and we should be able to, in the next few months, give to the world some sort of snapshot of where we are in terms of overall progress in these 5 indicators. Just to say a little bit about what are the targets, and you can see that the 5 key interventions are again listed under in the first column. And if you look at 2015, that shows you the baseline. And if you go to 2020 as well as 2030, what the global targets are. What's notable is harm reduction has a target of 300 new needles and syringes given to each injecting drug user per year. At the moment in 2015, our baseline was 27. This is supposed to go up to 200 in 2020. There's really a very large gap there. And you can see that for testing and treatment, again, we are not doing very well, because you are seeing that despite very, very cheap drugs, despite very, very cheap testing available in many settings, there is no access for many people for treatment. So what does the global strategy for elimination entail? As you can see, there is no clear indicators that have been agreed globally to say this is what a country should be doing in order to have the certification of the validation of its elimination. And these are the options that are being discussed within the World Health Organization. They are being looked at and discussed in terms of impact monitoring, in terms of service delivery coverage, in terms of how the programs are delivered. What are the equity and human rights issues in terms of how these programs should be delivered? Is stigma addressed? And in the way that we are working, are these gains sustainable? We are expecting to have some clear tools for this available in 2020. There has been some disruption around, a clear clear set of indicators that have been agreed by everybody. And these delays are also happening because of COVID and the focus on COVID. Many people are completely focused on that at the moment, And what that means is that hepatitis ends up being a lower priority in the mindsets of many people. Having said that, there is going to be a pilot testing protocol available for the last quarter of this year. And there are countries that are very, very keen to have the piloting of the validation protocol. I'm thinking of countries like Egypt that have really made remarkable progress in this area. Some of the issues around elimination and what that means have been researched, and there is data now to show that simplifying service delivery, having different models of service delivery, having micro-elimination plans, and very, very clear ways in which to address hard-to-reach populations will in fact contribute to a large progress that can be made in the elimination work that countries are doing. Elimination cannot work if it is targeted at no one. Elimination has to be targeted at the most difficult to reach populations as well as the easiest to reach populations are both important areas that need to be considered in any elimination strategy. What is very clear is that treating hepatitis till now has been seen as something that only hepatologists did. In many countries, it's not clear whether hepatologists or infectious disease physicians should be treating it. And there is clear evidence now to suggest that when you take hepatitis treatment out and you decentralize it in one-stop shops, as well as treatment in the community for injecting drug users, there is clear efficacy, there is clear possibility of taking hepatitis treatment outside of provincial as well as regional level treatment centers. This can be taken down to the level of a primary healthcare center with an MBBS doctor in some settings. In some settings, it will require a little bit more sophistication. Now, people say, oh, it's not possible to really eliminate hepatitis C. But we have seen one country, Egypt, that has a massive burden of hepatitis C. 4 to 5% of the general population was living with hepatitis C, is living with hepatitis C, and this was due to iatrogenic transmission. But look at the achievements in Egypt. And this is a story which can inspire all of us in all countries in our region. Between 2014 and 2018, Egypt, which happens to be a middle-income country with conflict, treated 2.4 million people. And the vast majority of those people were in fact treated by the state. Out-of-pocket expenditure was very limited, and you can see that the government has really taken very, very clear ownership of the program and did some market shaping as well as massive work around access to drugs as well as diagnostics at an affordable level, and has been able to put 2.4 million people on treatment. So if Egypt can do it, India can do it, Bangladesh can do it, Thailand can do it, Myanmar can do it, China can do it. A little bit about the region now. Where are we in the region? This data is data which is informal data that we have collected in the regional office, bringing together people from the programs. And we have some estimates of what is the prevalence of hepatitis B. And if we say that about 20% of these people need treatment, may have a high viral load, then out of those currently, only 9% are diagnosed and 4% have been put on treatment. For hepatitis C, similarly, if the 2017 estimates are saying that we have about 10.3 million people living with hepatitis, only about 8% of those are diagnosed. Out of those, 20% have been initiated on treatment, and about 89 to 90% have been cured. Overall, what this is showing is a clear picture that the programs are still nascent. The supply for treatment, as well as testing, as well as the demand for treatment, as well as testing, both need to go a long way. So what are some of the opportunities? What can we be doing so that when the conference happens in 2 years from now, these numbers are certainly much higher? The first is just to remember the opportunity of prevention remains with us. The opportunity of effective vaccination, of hepatitis birth dose coverage, as well as preventing mother-to-child transmission and injecting safety are very clear opportunities that we should be using to the best of our ability. WHO tomorrow is going to present its guidelines for prevention of mother-to-child transmission using antiretrovirals. I'm not going to speak about that, but that is a clear opportunity with very, very cheap drugs which are available to all of us to use. Harm reduction is another area of work where we have the opportunity to give people opioid substitution therapy, sterile injecting equipment. Injecting equipment is cheap. Opioid substitution therapy is also very cheap, and we should be able to use that as part of a comprehensive care and treatment package for people who are most at risk. In terms of diagnosis, we know that there are newer and simpler diagnostics out there. There are high throughput as well as point of care diagnostics available, as well as multi-disease platforms for testing. We have the Cepheid platform, which can be used for TB, for HIV, for hepatitis. And we have seen as a region the massive scale up of testing for COVID using RT-PCR, RNA testing, using the closed platforms, including the Cepheid platform. If we can scale up testing for COVID at the scale at which we've done it, we can also do it for hepatitis. These instruments will remain in the region, and they should be used to test and diagnose people and put them on treatment. A little bit about what is happening with hepatitis C. You all know that cure is possible now for the vast majority of people between 12 and 24 weeks. And the cost effectiveness of front-loading this in terms of preventing and managing sequelae has been established again and again. WHO has a calculator available, the Hep C calculator, as well as the hepatitis B calculator. I am not aware of a single country where treatment is not cost effective. Costs are also coming down. And I want to show you this graph to show you how much costs have come down. You can see that in the last 5 years, there has been a massive drop in costs. And in programs like the Indian program, the cost is actually lower than $40. A little bit about the major gaps. What are some of the challenges that we need to keep remembering as we go through this fight to eliminate hepatitis? The first is just to recognize always that this is a relatively new program. It's got limited funding, it's got limited staffing. In many countries, there's no clear home for the hepatitis program. Sometimes it sits with the HIV program, sometimes it sits with people who are focusing on vaccination, but there has to be clarity on how the hepatitis program is integrated into the universal healthcare program. There is no option here for a parallel program, but there is an option for a focused program within a universal healthcare context. The other clear challenge is really around data. We do not know where to focus our energy. We do not know always who to test. And this lack of strategic information, who, when, where, how, is something that the programs really need to find a way of moving beyond. There has to be investment in data through surveillance and information systems, and it does not have to be a separate platform. There are many platforms already that exist. There is the DHIS2 platform, which can be very helpful, and there are existing ways in which we can have real-time information recorded and reported, as we have done for tuberculosis, as we've done for HIV, as we do for malaria. These can be extended to hepatitis. The price reduction, even though there is a lot of generic drugs available in our region, we still hear of countries who say we are paying $300, we are paying $400 for hepatitis C drugs. There are challenges around how small countries with low volumes can actually access drugs. You look at a country like Sri Lanka, you look at a country like Bhutan, you look at a country like Timor-Leste. These are not large volumes. And there has to be ways of making sure that there can be pooled procurement and that the price reductions that are available to countries like India can actually be available to all countries in our region. The main issue around demand generation as well as supply that is still being raised again and again by key populations as well as service providers is that of stigma and discrimination. Perhaps we have not been able to show to the people who are living with hepatitis that there is empathy in the system for them. There are many doctors, there are many airline staff who have lost jobs, who are not allowed to actually get on training programs because of their hepatitis B status. And there has to be clear protection within the law that hepatitis B, hepatitis C, once you are under treatment, as long as your viral load is suppressed, as long as you're cured, you should not be discriminated against. Those legal protections are missing. There is also a lack of awareness in all populations, and this is compounded by asymptomatic acute infection. People do not know that they are sick. And there are no routine ways for people to check on their hepatitis B and hepatitis C statuses at the moment, because we haven't been able to even to focus on the high-risk populations. It's not clear how we can do this in the general population in many countries in our region. Finally, and most importantly, resource allocation. Resource allocation is yet to catch up with the disease burden. And I do want to remind all of us that the disease burden for hepatitis exceeds that of HIV, TB, and malaria combined. So what are the ways forward? What can we do? It's clear that elimination progress is still small and uneven. And I've just listed multiple challenges, underutilized opportunities for you. Every country has to believe that there is an investment case for ending hepatitis B as well as C. Countries need to have a national costed action plan, which is going to list out where they'll be able to focus, what they will do in the short term, what they will do in the medium to long term, and how those resources will be raised. A key issue is, how do we prevent the patients having to pay out-of-pocket costs for this? The recent price reductions have to be leveraged. We cannot allow the middleman in most of these countries to be making money and governments having to pay much more than they need to for people to get access to treatment. We must follow the evidence and we must prioritize key populations, and we have to find a way of addressing stigma and stigma reduction. There are many opportunities to do that. We can learn from the work that has been done in tuberculosis, the work that has been done in HIV, the work that has been done in leprosy and mental health. Hepatitis is not the only disease where there is issues around stigma and discrimination. Stigma and discrimination is a health system issue. All of our health systems must, within their governance, consider this issue. Finally, advocacy for international funding needs to happen constantly, but domestic resources is where we are going to find the majority of that financing. And financing innovation is critical to doing this. I'd like to stop here, and I'd like to thank all of you for your attention.
Thank you. You're the European face for the Asian and the American groups. Thank you very much, Patrick. And I would also include a few questions, and the plan that we had was that after every talk we would have some questions, but somehow in the second session they have put in, so there are some questions which have come up, and Dr. Ed Gain, who was in the initial first session, probably it is too late for you. Ed, are you available now? Or are you gone off to sleep? I wonder if Ed is around. It must be 11:30 or 12 in Australia. So I would request every panelist here and the speaker to be, all the speakers in the chairs to be part of the panel, but I'll start with Professor Patrick Kennedy, and I have two questions which have probably not been covered in this session. One is about what are the screening protocols for patients with chronic liver disease and cirrhosis that you are following now in the COVID-19 times? Are you calling the patients on the same time? Are you trying to do blood tests more often rather than doing imaging? Could you tell us how you and EASL is managing during COVID times the patients for surveillance for development of HCC?
Thanks, Shiv. Yeah, thank you again for the invitation. It's a pleasure to be here and listening to these excellent talks this afternoon. I think this is an important question, Shiv, that you raise. I think we've all faced it globally in terms of the public health emergency related to COVID. I think one of the key things, as the same in London and the UK as everywhere else, was the difficulty in getting patients certainly to our large acute hospitals. So one of the things that we looked at, and actually I've published a leading article in Gut on this, is I think the use of Hcc risk scores is a very important thing that we really need to focus on and use or bring more to the fore at this time. So I think in terms of Page B or MREACH B are good strategies for clinicians to use to risk stratify patients and to identify patients who may need to be screened earlier than others. I think that's the key thing here. So there's two elements to this. There's the prioritization of patients, and we can prioritize patients by using blood tests, asking people to have blood tests done locally without coming to their usual clinics or hospitals, but then also identifying those where we want to bring up earlier. So in my practice, as has been in the case in many practices, almost all HCC surveillance ceased for a number of months. And if that is the case, well, when we restart the surveillance, we want to be able to identify those at greatest risk and prioritize those. So I think this is really where HCC risk scores could be used as almost a stratification process. But also I think we as clinicians have maybe not used these scoring systems as much as we should have in the past. And like so many things in clinical medicine now, we're learning how we can maybe use some of these strategies better in the COVID era and then take them forward into our practice post-COVID. One of the things I would say is that as things have settled down, certainly in the UK a little bit, we're fortunate enough to have an early diagnostic centre, which was allowed us to shift surveillance and surveillance programs out of the actual usual radiology departments, but into very, very, I would say, dedicated early detection centres, which essentially allow us to undertake ultrasound in a safe, clean, COVID-free environment, and keeping patients away from the large hospitals, giving patients confidence, doctors confidence to be able to carry on with surveillance programs. So that's something that we've just managed to get going probably in the last 2 months or so.
Thank you.
Yeah, I would like to make a comment, Patrick. Yeah, so this is George from Hong Kong, Beijing, and I think that we have still some concern about using the risk score of HCC in chronic hepatitis B. And we have these discussions many times during the webinars of APASL. One of the problems, the risk score is very attractive, but we have to keep in mind that most of these risk scores have the HCC observed, but not to mention about the staging of the HCC. So in other words, lots of those studies does not address the issues of screening, because the purpose of screening is to detect early HCC. So I think that there are still a lot of work to be done. The Page B score is so far one of the best, very stringent criteria, and in our experience, it's applied pretty well. But when you talk about the ROCs and so on, it's still pretty unsatisfactory in real life. So I have reservations, because we don't have so far a very robust studies to show that early HCCs could be well identified with the use of this risk score.
No, I
raised a good point. I'm sorry, Patrick, in the interest of time, but he raised a good point, and I think the paper by you, the review and others, they say page B is like 100% or modified, reach B is like this and reach B. So people are sometimes confused. My suggestion is use all, whichever score you feel, but you can use all. But the point you made was very important, that we prioritize when we start full-fledged screening. I have to go on to 2 new questions, and that can be true for even Steve. Is do you use immunotherapy for HCC in and if Anna is around, if she hasn't walked to the hospital, if Anna is around, immunotherapy for HCC in the COVID days, you're using nivolumab or PD-L1 or VEGF and others?
Well, I'll start briefly, Shiv. I mean, again, almost all our oncology treatments ground to a halt at the very peak of the crisis. But as things have come back, we're looking at patients on an individual basis. And if patients are candidates for anti-PD-1 or anti-PD-L1 or immune checkpoint inhibitors, we're beginning to treat patients in the same way as before. So again, this is really about the practice returning to as close to normality as we can and providing the patients in the safest hospital environments and taking all the measures in terms of the management of the patients and reducing risk of exposure to COVID.
Well, any comments from our president, Professor Tausig Tanwande? What do you do in Thailand, and any suggestions in that?
Actually, we don't have COVID-19 in locally in Thailand at this time for 64 consecutive days.
Okay. George, any comments on this?
That's excellent. So we are having our 3rd outbreak right now, and we are very nervous. And we have more than 100 cases and record highs for the past 7 days.
Okay.
Difficult time. But for the patients for treated with immunotherapy or immune checkpoint for HCC, we try to maintain the service for these patients, especially those patients who have a good response to the therapy and also the TKI.
Same is being done at our place. I have 2 questions briefly for Stephen Locarnini, sorry. One is the triple therapy by J&J seems promising. Do you think it will see the light of the day in 2021? You have to unmute.
Yes, thank you, Shiv. Of course, I think that's going to be one of the most exciting developments in the hepatitis B treatment space over the next 6 months, because the data that I presented tonight was really from EASL, and so they've already got much more data to sort of add to what I presented today. And I think we're going to see patients achieving very, very, very good control, surface antigen negative, HPV RNA negativity. So I think this is going to lead us to the next most important issue about what happens from here. Are we going to see endogenous immune recovery by achieving this profound suppression? Is that going to translate into functional cure?
Patrick, any comments on that?
No, I completely agree with Stephen. I think this looks like a very exciting combination, and especially based around the siRNA therapies. Are we really going to see, these meaningful reductions in the viral antigen, allowing restoration of the immune response and providing functional cure? And I think it's a matter of time before we see, the real benefits of this and whether this will be the case. And then, of course, to what patient groups that these combination regimens will be best used in, and where we'll see the greatest benefit. So that's something that I think we're all going to see over the next 6 to 12 months, I hope.
To wrap up the HCC, if Masao is around, if not, maybe Saeed or George and Patrick can answer. What are the new algorithms for liver cancer? Do you think, how will you club SBRT, immunotherapy, and TACE or microwave? So is there some thought on this? Any new algorithm that you propose, especially in relation to the radiotherapy regimens, hypofractions or something? Yeah, Patrick?
Patrick, you are on mute.
Unmute.
I think that's a question probably better directed to somebody who's working more exclusively in HCC, Shiv.
Yes. I was looking for Masao in case he hasn't gone to the hospital. He's too busy nowadays, busier than when 5 years ago. Saeed, would you like to address this in any way?
Yes, thanks, Shiv. I think before we decide on an algorithm, the biggest thing for us is the cost. And that automatically decides the algorithm for us, because most of our patients are paying out of pocket. SBRT, we don't have one center even in Pakistan at the moment, which is a problem because we cannot import the radioisotope. It is considered to be a banned item. The immunotherapies have just come in, but my God, they're expensive, and one could easily get a liver transplant to a patient within this amount of money that they're spending on immunotherapy.
Maybe we have Dr. Kanda. Kanda, can you respond on behalf of Dr. Omata? Is Dr. Kanda there? Kanda? No. You probably can't hear us. So he was with Professor Omata. So he is. Are you responding by any chance? No. Okay.
Maybe I can make a few comments about the
reshaping. Sorry,
please. Yes. I think that the immune checkpoint therapies and also the TKIs is certainly going to reshape our current algorithms for the treatments of hepatocellular carcinoma, especially those beyond surgery. And the scenario I can see, and as Sid pointed out correctly, if the financial aspect is taken care of, we will expect to expand these measures to prevent even recurrence of HCC after the traditional therapies. And there are a lot to understand which tumors are going to respond to what type of therapy and whether combination therapies will work better in some of them. And I think a lot of the research, clinical research, needs to be done. And with all that, taking into considerations of the heterogeneous nature of the hepatocellular carcinoma itself. So the genetic markers and the protein markers, the tumor markers, and the status of the patients, the etiologies will all be taken into consideration. So what I'm trying to say is that I can see that in the future, and it actually happening right now in real life, that we are using different tools. So we have more tools to work on hepatocellular carcinoma, and we have amazing results. Some of our patients with advanced hepatocellular carcinoma, I presented in one of your meetings, which will be impossible to survive.
Thank you. Sorry, we need to be very brief. I have a bouncer for Steve, and bouncer is from Sihan, and it says, what about the stops? Stop. STOPS, stops. Yeah. What do you think about the S antigen stuff?
I think it's critical to be able to promote degradation and clearance of surface antigen from an infected hepatocyte. And I think I beg your pardon?
You think it has a future?
Oh, I think what's attractive about the apps and the stops, they're aptamers. They're very cheap to make. They're not complicated chemistry, and so they'll be able to roll them out if they show clinical benefit. The stops have, as I said in the presentation, they don't seem to have the immunological side effects of the naps that we're hearing from Replicor. We're not seeing that cytokine release and that hepatotoxicity. I think that's a big issue with the Replicor material, is that they've got to bring those flares under control a bit. Whereas the stops, certainly in the preclinical analysis, look far more, look, I think as a clinician, you'd be more comfortable using a stop than you would be a nap.
Okay. I can see Professor Kanda, and I see in the chat box. Professor Kanda, would you like to address something like algorithm or something you have worked on at Hcc a lot? And can you give your opinion? Yes, please.
Thank you.
Would you like to address anything on new therapies or algorithms for HCC?
No.
No. Okay.
Thank you.
Okay. I have some questions again for Dr. Kennedy, and maybe it can be Dr. Jidong Jia. Can we give nucleoside analogs in the first trimester of pregnancy? This is by Dr. Hanif. Ja, are you around?
Yes.
Jidong?
Yes. Yes.
Yes, sir. Can you give
this
nucleoside analog in first trimester?
First trimester, you mean?
Yes.
Yeah. Yes. Actually, we have that kind of data in Beijing, in mainland China. Is because some patients, they are already on nukes before they become pregnant. So in that situation, we will explain that this situation with the patients, so they decide, they make decision. Actually, we have the data. It is quite safe. Of course, we use tenofovir or telbivudin at that time. So the short answer is yes, but it's off-label use. We have to get the informed consent from the patients. Thank you.
All right, Patrick, any comments on this?
No, fully agreed. I mean, we know in terms of the safety data from HIV and many patients of ours who have chronic hepatitis B who are maintained on nukes who get pregnant, it's not an issue. But all the guidance is around the use where indicated of nukes in the third trimester starting at week 28. So we need to be clear about what the guidance is and clear about what is maybe safe or what is allowable.
Yes. Great.
Important. Professor Manoj is also heading this, maybe is Manoj around? Any comments, Manoj, on pregnancy and use of nucleoside analog in the first trimester?
So theoretically, it would be, theoretically, it seems intuitive that earlier we treat hepatitis B for prevention of transmission, it is better. But actually, there have been no randomized controlled trials in this area. Most of the studies, almost all of the studies have used nucleoside analogs at the beginning of the third trimester. But maybe it is pretty late. We need to have further trials because transmission of HPV can occur as early as the first trimester. So that's an open area which needs to be evaluated.
Right. Thank you. We have done a lot of work on this, giving it during first trimester compared to others, but another time. One more question that can be to maybe George and also to Sihan. How does corona reach liver, and why does it harm more the patients with liver? Any comments on this? Sihan? How does corona reach liver, And does it harm the liver more? And if so, how?
Yeah, yeah. Seance, can you make the comment first?
There are several aspects. First of all, in terms of the receptor, it is in biliary epithelial cells, and we do not see much change in alkaline phosphatase levels. So biliary epithelial cells do not play a role, most likely, in liver disease during the COVID infection. But on the other hand, indirectly, in patients with severe liver disease like cirrhosis, we have the additional insult of several issues, such as, which could be from hypoxic liver injury to cytokine storm, whatever, that most likely affects the liver. It's a multifactorial process, most likely.
George, any quick comments on this?
I think Shihans makes all the points. I think that's probably is not the direct liver injuries, more related to the cytokine storms, which is related to the overall pictures. Others are more minor, such as drug-induced liver injuries and also hypoxia cause liver injuries and so on. But having said that, I think there's one very important point actually raised by Anna, and I would like to stress is for those patients with hepatitis B, and if they have COVID-19, we might seriously consider preemptive therapy, especially even those with severe COVID-19, taking into considerations of the therapies which might be placed on these patients can cause severe reactivations of hepatitis B, such as one of them is the dexamethasones, which has been shown in some studies to be useful, and also the IL-6, which is being used in some part of the world for the treatments for COVID-19.
Okay. Dr. Tanwandi, there is a question. In one of your slides, you showed that use the most potent antiviral drug. What do you mean? Which drug is the most potent according to you? And also whether you would like a sequential therapy or a combination therapy for hepatitis B patients?
Actually, there's no there's some direct comparison, but what I mean by potent antiviral drugs for the oral drug could be either entecavir or tenofovir or TAF. All of those three compounds are among the most potent that can reduce the virus up to almost 7 log reduction during the clinical trial. And for using sequential, is that the sequential nuke or sequential nuke and PEG?
Regulated interferon and nukes.
There was some study regarding either sequential or adding or combinations of PEG, interferon, and nuke, and some beneficial effect of combination, but still in a large controlled trial study, we haven't had any significant benefit of combination or sequential use of the compound, but in a small study you can see some benefit. I think we need more data before we give any additional recommendation in using those.
All right, we have some questions for the excellent talk by Dr. Saeed and Dr. Mukta. Saeed, you told that the vaccination programs are suffering and also the care in hepatitis B. Do you think there is a need for an advisory by maybe combined WGO, APASL, or maybe other groups, so that policies don't go into the back seat. And you also had a survey done. So would you like to educate on steps to be taken for bringing hepatitis B programs on the front seat again?
So what many programs have done, they have gone to the people instead. They've gone to the communities. They have gone out of their centers and gone to the communities. I think that is one way of doing this. There is a lot of stigma also around the diagnosis of COVID, unfortunately, in our countries because of the test and isolate business and so on. And therefore, people are not very willing even to engage with healthcare professionals. We do our community work on hepatitis C microelimination, and before we were getting very good responses, and now when we approach communities, they think we are there for COVID testing, and they check us out. So it has got to be a slow restart. I think an advisory would be a very good idea, so that the programs can have something to get their strength from. So I would certainly want to encourage that if possible.
Yes, you are the chair of the Hepatitis and Hepatology Interest Group. Dr. Mukta from WHO, you and Dr. Revari, although the names seem Indian, but you have a huge global presence. Would you advise some, reformatting done at WHO or policymakers for hepatitis programs?
Thank you. Thank you for the question, Dr. Sareen. I didn't fully understand what you meant by reformatting. You mean in the way the program is delivered?
You bring it back to the front row. How do you do that? And can WHO or an internal discussion between the groups can help this?
Right. Thank you for the question. We are struggling with how to present this to policymakers. The policymakers say to us, it's not just the hepatitis program that's suffering. It is the TB program that's suffering. It is the HIV program that's suffering. It's the immunization program that's suffering. And the question really becomes, what does the health system need to do when it is under shock? And what priorities are set in those contexts? Now, if you look at our region, we've got very different situations. You've got a lockdown, a very severe draconic lockdown in some countries. And in some countries like Myanmar, just 366 COVID cases. Thailand, no local transmission. So there's no one policy prescription. The main issue here is, can we get the system to continue to communicate with the patients? And can the patients find a way of accessing treatments, either by taking it to them, as Professor Saeed has said? We've seen that happen for HIV. We've had people being given their drugs in the community by using people who are in the community. So we've made these prescriptions, but I think for hepatitis, it's been harder because people feel that it's not immediately life-threatening. It's not like tuberculosis, where you will, immediately have a problem and you will infect so many other people. And those are some perception issues. So I agree that, policy prescriptions need to be made. The role of the community, the role of decentralization and outreach workers, going out to people, making sure that there's treatment continuity is important. But at the same time, what we're really struggling with is people haven't been put on treatment. People haven't been diagnosed. The numbers of people are very limited.
Sorry, Mukta, we have to be brief. We have only 2 minutes left. This question was remodeled based on Dr. David Wiljoho from Indonesia, who wrote a long chat, and you can answer him directly.
Certainly. But I think the only thing I will say to summarize is, yes, there has to be a different policy prescription, but there can't be one, because COVID has impacted countries very differently in different places. That's all that I wanted to say. And it needs to be a health system response, not just specific to hepatitis. Thank you.
Can I just say just one sentence? I think we need to also reframe the message. We've been talking about hepatitis kills more people than HIV, tuberculosis, and malaria put together. Now we need to repurpose that to say hepatitis in certain countries certainly kills many more people than COVID does. With due deference to people who died of COVID, there have been dramatic deaths, and there have been deaths that have been very close to us. But on a scale of the whole country, Pakistan gets about 110 to 120 deaths per day with hepatitis. We've occasionally touched 200 deaths per day with COVID. We are much less than 100 in normal terms. Thank you.
Thank you, Saeed. And I would like to take this opportunity of just putting our president, APASL, Dr. Tanwandi, who has a board behind his chair, says that the next APASL is in Thailand, and from 4th to 6th of February, just a noting point. And with that in mind, and I would like, Patrick, are you likely to give us some more last minute advices? Is Patrick Kennedy still connected? Patrick from Europe? Patrick?
Yeah, thank you, Shiv. I'm not sure. I'm not sure what more advice we can give. We're seeing similar peaks in mainland Europe and Spain. Again, there are changes on travel restrictions based on the very fluid picture that we're seeing. So we've had a difficult couple of months, but I don't think we're quite out of the woods yet. So we've got work to do.
All right, with EASL coming, and maybe some policy decisions on hepatitis can be taken there in the COVID times. On behalf of the steering committee, on behalf of my other colleagues in APASL and all the chairpersons and panelists, I would like to thank everyone for joining us. And I also like to thank APASL Secretariat, Izumi, in particular. At the best of our times, we had about 270 plus people. We have dropped down to 192, as I say, but I do hope the message will go far and wide. And I thank WGO, the president, and the members for taking this mass appeal on World Hepatitis Day. I would like to one more time say a great respect and regard to our own Professor Roger Williams, whom we have lost, and prayers to his soul. I would like to say thank you to everyone. Thank you all.
Thank you. Bye-bye.
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 Thank you very much. Thank you.
Bye-bye.
Bye.
Thank you very much to everybody. Thank you.
Thanks.
Bye.